It's a pleasure to speak with you today, and I hope to make this an enjoyable presentation and share with you things that are really what I believe is really impacting medicine and also a lot of chronic disorders that individuals are suffering from that now have answers to. And we believe that this will lead to many other breakthroughs in the area of neurologic, psychiatric, and behavioral disorders. So let me start by sharing, as Ashley mentioned, we're going to talk about neurologic, psychiatric, and behavioral symptoms that don't respond to typical treatments. And then we're going to talk about how infections can trigger the immune system to disrupt the brain and interfere with brain functions, and how they interfere with the biomarker targets that we identify in the autoimmune brain panel. And do feel free to insert your questions in the question Q&A section, and we'll get to that at the end of the talk. So my disclaimer statement is this webinar is intended for informational purposes today, and that the information that I'll share with you is not intended to be healthcare advice for a specific medical problem, but it is really important that you seek medical professional advice from a qualified healthcare provider. And with that, let me share with you what we're going to talk about today. So first, we're going to start with a basic understanding of the biological background and how infections can really trigger these neuropsychiatric symptoms. And then we're going to move to how can infections trigger these immune-mediated psychiatric disorders that you may have heard about, like PANDAS and PANS, neurologic Lyme, and even long COVID. But basically, we're going to talk about the interaction between the immune system, the infections, and the brain. And then we'll review some case studies for patients and show the different therapeutic and treatment categories that have shown to be clinically effective in treating these immune-mediated disorders. And then we'll talk about how the biological targets that are in the autoimmune brain panel can help your doctor diagnose and treat these conditions. So with that, I just want to share with you a little bit about our background, why we actually founded Moleculera Biosciences. It started with a clinical study that were recruiting patients who were suffering from these neuropsychiatric and behavioral disorders. And it started with Dr. Susan Sweeto at the National Institutes of Mental Health, my co-founder, Dr. Madeline Cunningham at the University of Oklahoma. And this clinical study, excuse me, had identified patients, and these were children, who had developed sudden onset of obsessive compulsive disorder, motor tics, and other types of symptoms, but then they were preceded by a strep infection. Now, it was found that many of these other children had other infections, but they wanted to study this specifically with a single infectious agent. So during this study, the patients got tested, treated, and they recovered remarkably. And then, of course, the clinical study concluded there was about 1,000 patients enrolled in this study. But then these parents began to tell other parents, and calls kept coming in to the university over a year wanting to be included in the study, which there was no study because it was over. And then patients were continually looking for help, spending tens of thousands of dollars on medical help with little improvement in treatment. And one of the comments from one of the parents was that we watched hopelessly as our dear children lose chunks of their childhood to something so few currently understand. And this is really the genesis of why we started the company, because there was a need and there was an outcry for help and wanting to be able to be tested and included in how we actually were be able to help them with the diagnosis and the treatment. One other thing that we did is we looked at the financial impact on these parents with children with autoimmune, neurologic, and psychiatric behavioral disorders. And these are some of the write-in comments of over 50 questions that we provided. And what we found from all of this, after testing over 15,000 patients now from over 50 different countries, that we had found that they had seen between 5 and 15 doctors before they ever reached a proper diagnosis. And we found that from the time of symptom onset to the diagnosis was actually 3 to 5 years, with another somewhere between 3 and 18 additional months before they ever received effective treatment. So this was a plight that we really understood, and there was a lot of suffering going on. And our goal was to how can we help impact and transform how medicine is practiced for these people with different disorders. So let me start with a little bit about background of how neurologic, psychiatric, and behavioral disorders are diagnosed and classified. And excuse me, I'm still getting over a sinus infection, but and allergies, so apologize for coughing or anything here. These symptom categories that you see, obsessions, tics, repetitive behavior, hyperactivity, etc., are clusters of symptoms that are identified and then placed into these categories under a DSM-5 codes as to what type of diagnosis these patients might have. So for instance, if an individual has motor or vocal tics for more than 12 months with other certain criteria, that is the definition of Tourette syndrome. You can see hyperactivity, separation anxiety, irritability, etc. Many of these different symptoms comprise a diagnosis of ADHD. And so the point here is that categories for these diagnoses for different neurologic, psychiatric, and behavioral disorders are classified by symptoms, not etiology, meaning that symptoms, not the underlying root cause, is what constitutes the diagnosis. And we know that psychiatric disorders are diagnosed entirely on presentation, not biology, at least today. Yet these disorders have a wide range of symptoms and causes with varying response to treatment. And here's where the challenge comes in. Because they have a different underlying cause or etiology, they don't respond to the traditional treatments that are used for these different disorders. So what's contributing to this delay in the diagnosis and the confusion and maybe some of the chronicity of these disorders? One is the medical specialization. So it unintentionally makes it difficult to diagnose and treat these types of disorders because the prevailing model is that psychiatry and psychology is practiced separately from immunology, practiced separately from infectious disease, and practiced separately from neurology. When we know, in fact, that the body is integrated and that infectious diseases actually can impact the psychology, the psychiatry, the neurology, and of course, the immunology. And so because the integrated view of disease biology is not how the medical specializations are set up currently, that when you find cross-disciplinary and collaborative medical care, you can actually accelerate the diagnosis and treatment of these chronic disorders. So this is a current challenge due to an unintended specialization in medicine, which has led to, as I mentioned, many of these patients seeing between 5 and 15 doctors before receiving a proper diagnosis. But we believe that that's changing as more and more research is being recognized and more information is being presented. So let's ask the question, how can infections trigger an autoimmune response that leads to these different types of neuropsychiatric disorders? Well, JAMA Psychiatry in 2019 published a study that was done in Denmark that followed over 1 million individuals from birth to age 18. And in that study, what they found out that if any one of those patients were hospitalized for a severe infection, that the risk of developing a mental disorder increased by more than 80% for schizophrenia, autism, OCD, ADD, ADHD, personality and behavioral disorders, oppositional defiant disorders, tic disorders, and many other disorders. So the question from the editors was, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? And they said that circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation And this mechanism has been proposed in PANDAS and other mental disorders. So we're going to talk about these neurotransmitter receptors, and we're going to talk about these autoantibodies that are directed against these neurotransmitters and how this actually can help identify and provide a proper diagnosis that can lead to successful treatment. Because we do know that a large portion of these different neuropsychiatric disorders are caused by an infection-triggered autoimmune dysfunction. Now, if you take a step back, we do accept and understand that other immune-mediated disorders are caused by an immune system response. We know that rheumatoid arthritis is the immune system attacking the joints and the cartilage, creating inflammation. We know that diabetes type 1 is an immune system attack against the insulin-producing cells in the pancreas. We know that multiple sclerosis is an immune system attack against the myelin and the insulation around the nerve fibers. But when it comes to the brain, we have not completely yet accepted or fully understand at a broad scale that antibodies can actually cross the blood-brain barrier, attack parts of the brain that result in the diagnosis or the presumptive diagnosis of different disorders that might be called autism, ADD, schizophrenia, bipolar, of course, PANDAS and PANS. And the immune system is actually the culprit in this case. So we think about, how does this really occur biologically? What's going on indeed? Well, again, it starts with an infection, and we all get infections. We get bacteria, virus, fungus, all types of infections. And our body normally does very well by producing a response and antibodies that recognize these infections and these organisms. And that's how we are able to stay healthy. And this process is what normally occurs. However, in some individuals, and I say some individuals, and we'll talk about what that actually constitutes, is that in these individuals, the antibodies that they actually develop cross-react with different types of neurologic receptors in the brain, as was mentioned in the JAMA Psychiatry article. We call that process molecular mimicry because there's a mimic looking like something else, and the antibodies that are made cross-react with something else. In this case, it's the brain. And what we think of sometimes in the wartime as friendly fire, where you can't tell the difference between the good troops and the enemy troops. But sometimes what happens is the strongest forces begin to attack our own forces, and in this case, it's attacking ourselves. What happens then is these antibodies cross the blood-brain barrier, resulting in symptoms that can be known as anxiety, aggression, rage, OCD, tics, depression, etc. And what we find is the standard of care is to treat them with the psychotropic drugs. And because this is an underlying and immune-mediated disorder, that these patients typically are treatment resistant, meaning they don't respond to these medications. In fact, often you'll see that patients will actually get worse on sometimes many of these medications. However, they do respond to treatments that modulate the immune system, treatments that actually get rid of the underlying organisms that are bacteria and viruses, and things that reduce the inflammation. And we see some remarkable recoveries, and we'll talk about some of those in just a little bit. So you may have heard about the term PANDAS and PANS, and these are two conditions that becoming more well recognized, and it's the term PANDAS is an acronym for pediatric autoimmune neuropsychiatric disorder that's associated with a strep infection. Again, not the marsupial, but it's actually a condition in which is preceded by a strep infection, as was mentioned here as to why the company got started. Dr. Susan Sweeto studied this at the National Institutes of Mental Health, and she coined that term and published paper and multiple papers, but back in the late 90s about the first 50 cases. So let me talk about, because sometimes there's confusion in the nomenclature, PANDAS and PANS. So let me start with PANDAS. We know what that stands for. But strep is not always the triggering agent. Sometimes can be Lyme, could be mycoplasma, Babesia, Bartonella, and other microbes. And sometimes there's a belief that environmental factors and other biological factors can contribute. So there are two categories, the infectious triggers and the non-infectious triggers. And this is where PANS, the term PANS came into being actually around 2015, because it was recognized that strep wasn't the only trigger. And so PANS does not refer to strep, but it refers to just the acute onset of these neuropsychiatric syndrome in children. Now, what happens if you're not a child? Well, there's been other terms that have been coined, like ANDL, autoimmune or adult neuropsychiatric disorder associated with Lyme. But these also can be referred to as an autoimmune encephalopathy or a basal ganglia encephalitis, and that's because that part of the brain is where the antibodies seem to be the most prevalent in attacking. But overall, what we know is this is an autoimmune dysfunction that's resulting in these neuropsychiatric and behavioral symptoms that are triggered by an infection. So if you're an adult, you can't have PANDAS. If you didn't have strep, then you can't have PANDAS. You can have PANS, but if you're an adult, you can't have PANS either. And if it wasn't acute onset, you can't have PANS or PANDAS. So there is some nomenclature confusion because these could still be the same biological model and they could still respond to similar treatments, but they may not have those labels. So this is a part of an area of nomenclature that sometimes brings in confusion. I want you to be familiar with that. So we have, as a clinical lab and as a biotechnology company, tested over 15,000 patients since we've been in existence from over 50 different countries. And many of them had, as you can see, these presumptive diagnoses that I've mentioned here. What we have found is that 85% of them have had one or more of these 5 different autoantibody targets that have been present, and therefore these patients have been able to be treated with different medications and respond to treatment. So another way of looking at this in sort of a tongue-in-cheek manner is many people in this area are taught never to think outside the box. But what you have to realize is there is really a true connection between infections, the immune system, and the brain. It has to be something that you're actually looking for. So what are those infections and what kind of infections do you really tend to see and hear? So I'm going to move over to talk a little bit about molecular mimicry briefly, and then we'll go into the targets they're directed against. So we do see, obviously, with strep. Strep also is a known cause of Sydenham chorea, influenza, varicella, mycoplasma, Lyme or Borrelia, Babesia, Bartonella, Coxsackie, and we also see with SARS-CoV-2 or COVID that it can and it has reports of triggering this or re-triggering it in patients who have already experienced these conditions. So how does this work? I'm going to give you a simplified biological explanation. We make antibodies against different what's called epitopes. So if a strep bacteria, we make lots of antibodies against different parts, but if some of them are made against an epitope that has a certain sequence that's identical to a, let's call it a nerve, then once it's made, it's going to cross-react with a nerve cell or a receptor in the brain, or for other disorders, as I mentioned, such as rheumatoid arthritis or diabetes type 1, the target is different. That's what we call molecular mimicry. And to simplify it, molecular mimicry, as I mentioned, can be thought of as friendly fire. Not sure why that term came along as friendly fire, but it's a breakdown of self, non-self discrimination. And we won't go into the genetics, but it's typically related to family histories that have genetic changes or modifications in these locations, the major histocompatibilities and the HLA antigens class 1 and class 2. So what we do see is that you can frequently see a family history of autoimmune dysfunction that's typically associated with patients with these immune-mediated neuropsychiatric disorders. This could be lupus, MS, asthma, psoriasis, many different things, but it does give a predisposition for a self, non-self discrimination issue. So this is where we come in, the importance of precision medicine in diagnosing and treating these patients. What you see here is that patients presenting with similar symptoms can be grouped into those that are immune-mediated or respond to immune modulators, anti-inflammatory agents, and anti-infectives, and those who would respond to traditional psychotropic medications. Because prior to that, they're all treated the same because they're all treating symptoms. And I think I've got this twice, so I'm going to move through here. So if you look at this from the biological side, what you can see is that these antibodies that are the purple ones are binding to pre- and postsynaptic neurons, and particularly these receptors, dopamine D1 receptor, dopamine D2 receptor, lysoganglioside tubulin, and CAM kinase we'll talk about in a moment. These can be shown here in a study that's been published, that patients for CAM kinase have normal activation, and then those with PANDAS and PANS have elevated activations. So we run 5 different tests, and these are here in the autoimmune brain panel. As I mentioned, this is what the results would look like. We look at, does the patient have autoimmune antibodies that are directed against dopamine D1? And I'll talk for a little bit in a minute here about what that means. Do they have antibodies against dopamine D2 receptor, which is another brain receptor? Do they have autoantibodies against lysoganglioside GM1, which is actually the myelin sheath around these nerve cells? Do they have antibodies against tubulin, which is an intracellular structure that's located in the brain cells? And do they have antibodies that can stimulate what we call this kinase activity? Excuse me. So what does that mean? Well, what we have found after testing this large number of patients, what we have found is that antibodies directed against dopamine D1 are associated with psychiatric symptoms, and they tend to see mood instability, different types of sleep disturbance, sensory and motor abnormalities. So more so when they're just responding to antibodies against dopamine D2, we see movement symptoms such as choreiform movements, hyperactivity, excuse me, and various others. And you can see these show up in these patients. When they have antibodies against tubulin and lysoganglioside GM1, we see with tubulin complaints of brain fog and associations with obsessive compulsive disorders. When they're directed against lysoganglioside GM1, we tend to see associations with motor tics and other types of joints and connective tissue pain. When we see antibodies that stimulate the CAM kinase activity, we see an activation of anything related to the fight or flight behavior, meaning they could be easily startled. They might have separation anxiety. They might have other types of urinary and bedwetting problems. And so we look for all 5 of these because patients present with different and heterogeneous symptoms, which is why it's been, I would say maybe controversial in the sense, why they have different symptoms. because they have different targets directed against different parts of their brain. So let me move to some of the case studies so you can see really how this it plays out in some of these patients. This is an 8-year-old young girl who had an abrupt onset of OCD, vocal tics, poor concentration, sensory and motor abnormalities, emotional ability regression, aggression dysgraphia, and the parents reported urinary and sleep problems. So we had tested her. She had antibodies against the lysoganglioside GM1, elevated antibodies against tubulin. She had a relapsing remitting symptoms. She was diagnosed with anxiety, OCD, and her lab results for looking for strep really were not remarkable. And so strep can actually be found in many different orifices of the body, or it can be sometimes missed. But she did have a significant history for 2 streptococcal infections, a fever, sore throat, sinus pain, and frequent ear infections, sinus infections, and fevers. She also had a family history positive for mycoplasma, autoimmune disorders, and frequent bacterial and viral infections. This was a case in which was caught early, which is what we really love to see, is because the immune system hadn't gotten strong enough in the patient. And they treated her with 1 course of azithromycin, rapid improvement of the symptoms, and all the symptoms resolved. She returned to baseline after 2 to 3 days of treatment, and both her antibodies returned to normal ranges. This is another case study of a 16-year-old girl, and she presented with an abrupt onset at age 11. She had an OCD which manifested as a food restriction. So sometimes you'll see what looks like potentially anorexia, but it's really an OCD in these cases of a fear of choking, a fear of food contamination, a fear of vomiting, tics and creiform movements, poor concentration, and aggressive behavior in this case that prompted 6 calls to the police. So she had an elevated calmodulin CAM kinase stimulation activity. She had relapsing remitting symptoms and sudden increase after another strep exposure. So she did have a diagnosis of autoimmune diseases, other types of diseases involving the immune system. In this case, she was positive for a Lyme and elevated mycoplasma and Coxsackie virus. And the family history showed that the grandmother and the maternal and paternal grandmothers had autoimmune disorders and rheumatic fever, which is rheumatic fever is a cross-reactive response of antibodies to strep that attack the heart. And she had siblings with PANDAS. So what they did was treated her with plasmapheresis and IVIG with symptom improvement. They gave some low-dose Zoloft, Abilify for maintenance. Again, the low dose is because the standard doses actually exacerbate these, and significant symptom improvement, CAM kinase return to normal range. Another one of a 24-year-old young female. We actually have more males. I think these cases were ones that we had pre and post treatment, but gradual onset. So sometimes it's not sudden onset. Poor concentration, emotional ability, developmental regression, and sleep disturbances. In this case, she was positive for dopamine D2 antibodies and a calmodulin CAM kinase activation. Again, I'll move through these a little more quicker, but peripheral neuropathy, some reflex sympathetic dystrophy, Lyme disease, and then diagnosed with a disorder of the autonomic nervous system. Her lab results, which is what they will check for often when they'll see positives, are there any organisms such as viruses, bacteria, that actually could be triggering the immune system? Turned out she was positive for strep, Lyme, babesia, mycoplasma, Epstein-Barr, and herpes. And this is not unusual. We see multiple infections because the immune system becomes compromised. The family history was, or I said medical history, frequent strep infections, and frequent dental infections. Her family history was positive for autoimmune disease. This case required a bit more because of the age and the duration and the length of time that the patient had this, but she was treated with 4 courses of rituximab and some ozone treatment for the doctor that prescribed that. Significant reduction in symptoms. Both her dopamine D1 and her CAM kinase returned back to normal range. I'll leave you with one more study. This was published from a patient that was at the Cincinnati Children's Hospital. She was actually diagnosed with schizophrenia, had psychosis, severe anxiety, and depression, and she was in and out of treatment facilities. The doctor that was called in was an immunologist and was then ordered the autoimmune brain panel, and they published the results. She had elevated antibodies against dopamine D1, D2, lysoganglioside, and tubulin. And she was treated with 1 course of plasmapheresis, and the patient had complete resolution of her psychiatric OCD and anxiety and was weaned off of olanzapine and resumed her normal activities, including tennis, within 2 weeks after plasmapheresis. Now, plasmapheresis will remove all the antibodies, and the response has been sustained for over 6 months, consistent with the previous studies. So, what does this really all summarize? How are these patients treated? I shared how we diagnose and identify them, or how they actually are diagnosed by the doctor, but the panel helps identify that there is an immune dysfunction. The first thing is to identify and treat all the infections, because again, these are the things that are triggering the immune system. And if they're positive with the autoimmune brain panel, they will look for multiple offending infections. Sometimes, as you saw, symptomatic relief is necessary, and these are low-dose SSRIs. Treating the inflammation, because the brain then can become inflamed, and then treating the immune dysfunction and immune dysregulation. So if we were to look at what are some of the common symptoms that you see that patients actually are positive in the autoimmune brain panel, well, some of those symptoms are that they're resistant to standard neuropsychiatric drugs. That's one thing that we see quite frequently. They have frequent infections, but these infections can also be subclinical, meaning they don't manifest the symptoms as being sick. They can be diagnosed with neurologic Lyme, or what's known as post-treatment Lyme disease. And as mentioned, they can have family histories of autoimmune disorders. Sometimes there's sudden or rapid onset. But again, sometimes they're gradual, but one of the requirements for PANDAS and PANS diagnosis is it has to be a sudden onset. Sudden or rapid onset of OCD, and as I mentioned, these restrictive eating disorders. But these again are OCDs because they're fear of food contamination, food phobias, and also fear of choking, or maybe even fear of vomiting food. Local motor or vocal tics and choreiform movements, which are the small movements of the fingers, piano playing movements, anxiety, rage, separation anxiety, emotional ability, and the actual relapsing and remitting of these. Depression is another symptom, developmental or behavioral regression, and often maybe a certain percentage you can see dilated pupils. Mydriasis, typically when the CAM kinase is positive. Urinary frequency or bedwetting in children who actually, are beyond the age of that. I mentioned relapsing, remitting. One of the doctors, the pediatric neurologist that we work with and sees many, many patients from this, has said every single one of them has experienced suicidal ideation. You just have to ask them, because you're interrupting the brain function, you're interrupting thought processes and cognition, and that's what they see. Obviously, PANDAS and PANS diagnosis. But the good news is we have multiple, in fact, hundreds of patient stories. You can go to our website and see these and read these. This is Grace, who was diagnosed with ADHD, oppositional defiance. They diagnosed her with a mental disorder at age 8. She wanted to kill herself. and the parents emptied their 401k twice with no answers. They found us, we tested her, she was treated by her physician for the underlying autoimmune condition. Her mother sent us this picture of her completely well, back to normal life, and on the cheer team. Adam, a young boy who was diagnosed with ADHD, they also thought maybe he had autism, but they were thinking about putting him in an institution because they really were unable to continue to care for him. They were tested, the doctor treated him, and the mother sent us this picture of him running cross country, saying recovery is possible. He's 10,000 times better. So the process for ordering testing, the result process here is we require that you have a physician's order in order to do that. We know that sometimes physicians and clinicians may not be familiar with an infection-triggered autoimmune process, but we have medical and clinical people on staff that we can help with both in-service and education, training and help anyone that is interested, and we do this in many medical talks. Once that order is placed from the doctor, blood tubes then are collected. We send out kits. The price of the kit, price of the testing of all 5 on the panel costs $995, and we request a $495 deposit in order to cover the cost of at least getting it started. FedEx will pick up the kit and will come to us overnight. We will test for all 5 autoantibodies and the CAM kinase stimulation, which is growing human brain cells in culture and incubating them with the serum and then pulse chasing them with radiolabeled P32. These take 2 to 3 weeks to complete all these assays. And then it goes into the system where the healthcare provider is notified. The results are uploaded automatically, and then the physician is notified. We provide courtesy billing to your patient's medical insurance, and often we will see that they will pay depending on the coverage, or sometimes it'll go to deductible. The physician will then have access to the report. The physician or the clinician or the provider can call us. We have clinical staff on site that will work with the physician or the clinician as to what some of the needs are, the background, maybe some of the information about different treatment modalities. If you're looking for how to order it and you don't have a doctor that actually understands this, you can go to our website, and in the website there is a link as to download a test requisition. So you can download the test requisition, take it to your physician, and provide it to them and talk to them about that. Again, we can provide consultation to medical staff on this. And this is how we actually get more and more doctors who are aware of this. As of today, we have over 2,500 doctors who have now placed orders, and that number keeps growing. So in bringing this to a conclusion, there are many references here, books that you can read, stories about different elements of what we might call autoimmune encephalopathies, basal ganglia encephalitis, PANDAS and PANS. But basically, it's an immune-mediated neuropsychiatric disorder triggered by an infection. So these are some resources that you can find. Again, you can go to our website. We have publications, we have videos, we have educational brochures, and that's at www.moleculera.com. If you have any questions about how to get the blood drawing at a station, we partner with Quest Diagnostics, or any questions about the insurance, you can call our office number at 405-239-5250. We do provide some support for clinicians through our medical and clinical staff, but these will be directed to the doctors and the clinicians. And then with that, I'm going to leave you with one other thing here. We're working together with other doctors and helping to understand this area of medicine that involves the immune system and chronic illnesses that many people are suffering from. So there is a conference that'll be held in Phoenix, and it will be also virtual, April 3 to 5 in 2025. And the website is there. You'll be able to register for it or get emails notifying you when that's available. But there will be a multidiscipline group of doctors, researchers, and even probably some patients here describing in great detail more about these different disorders and the area of medicine that we believe is going to help change how these chronic disorders are treated. So with that, I'm going to pause and stop and see if anybody has any questions. And thank you for attending and listening. And we appreciate your interest in this area. And we're here to help. And our goal is to bring hope and healing to families who are hurting from these types of disorders.
Thank you, Dr. Shimasaki. That was a great presentation. Do we have any questions? If you can either type them into the chat or the Q&A, and I can read them off for Dr. Shimasaki, or you can also raise your hand, and I believe through that function, you can ask your question directly to Dr. Shimasaki. We had one. We had a hand raised. There we are. You're on mute. There we go.
Can you hear me?
Yeah.
We sure can.
Okay. So, you know, what we're talking about here so much is an infection, a bacteria or virus or what have you, causing the immune system to become a bad guy. The case that I'm interested in, and it's very specific, and I know you probably don't want to just go into everybody's sad stories, but basically, a 16-year-old experienced all of the symptoms of lupus. What we'll call it, or what I'm reading is we call it drug-induced lupus. She was on minocycline to defeat acne, and she began to experience all of the symptoms of lupus. And they persisted for months and months. The reason this diagnosis is asserted here is that we took her off the minocycline, and in 60 days, the lupus symptoms disappeared. Subsequent to this, she began to experience depression, anxiety, sleeping disorders, eating disorders, and eventually seizures. She's been experiencing this for 20 years. Assistance, all of the assorted therapies that have been tried. So in this particular case, it appears that the immune system became a bad guy, maybe not because of an outside bacteria, a living thing, but because of the use of this antibiotic. And of course, I'm a layman, and I can't, fill in any of the pieces. I'm trying to give you the major blocks here. The question really is, do the treatments that you have found effective, which are actually attacking infections that still exist, do these treatments actually work on fixing the neurons that may have been blown haywire by such an event as I have just described, which we are presuming was not caused by an infection or a bacteria? Of course, who knows how they're all working together. But do you have any comments on a situation like this? Where, I think we have a physician who will encourage this test, but really, are the treatments available simply designed to beat a germ that's sitting there, or can we work with this situation I've just described to you?
Yeah, first of all, you described something that really is a sad situation when a patient is being treated for something that's common like acne with a drug that has an ability to dysregulate the immune system in some way. It is not rare that that does occur with minocycline, although it's not as frequent, but it has been reported. And because some of these antibiotics, they affect different areas of the body and different areas of the biological system, they can have side effects such as, in this case, triggering lupus-like syndrome. Again, the issue that we're talking about here is where the immune system becomes chronically dysregulated, and you find these antibodies that are attacking the brain. So in that area, certainly there may be a role for testing to see if the individual might have autoimmune antibodies against other parts in these cases. The question might be, is the patient suffering from any of these other neurologic, psychiatric, or behavioral symptoms? Because these are actually the targets in which we're looking for. If that's the case, then many of these immune modulatory treatments could and might be helpful in ameliorating some of these symptoms. So this is an area, as you probably know, has probably been finding out, and maybe not a lot of doctors understanding it completely of how to treat it, but it's one of those areas that has an immune system dysfunction component to it. And if so, that there's these antibodies that are directed against the brain, that often treatments that do help, if that's the case, end up being immune modulatory anti-infectives and others such as that. I don't know if that answered your question directly, but it is one of those areas that I think you'll have to find some specialists in the area of either rheumatology or other areas that might be able to help.
Do you think that your panel would be valuable in diagnosing this patient?
Again, I think that there could be some value there, because if the patient is actually suffering from various types of symptoms in addition to the lupus symptoms, such as the anxiety, the different types of OCD, psychiatric, neurologic, then the answer could be yes. We do have medical and clinical staff that probably would be a good thing to talk through and ask. But I would say that the possibility is yes, I wouldn't want to try to diagnose this, but I would say that if there are other symptoms that fall into those categories that we described, that it could be possible that the testing could be of use to help get to what could be some treatments that would help all of these symptoms.
Thank you.
Mm-hmm.
All right. So we have a couple of questions, Dr. Shimasaki. The first one is it's a two-part question. What percentage of people with OCD have an autoimmune connection? Do you have that figure off the top of your head?
That's a really good question. In fact, just last week, I returned from speaking at the International OCD Foundation on autoimmune OCD. We do know that OCD is not an infrequent, but more common than we believe. And there are multiple triggers and causes for OCD. One of them is autoimmune. It is not completely understood what percentage is, but I would say that if we look at literature and many of the different parts of literature that show patients who don't respond to these traditional medications, the the literature supports that it could be somewhere between maybe 20 to 60%. Again, that's backing into a number through patients who aren't responding and don't get treated for the OCD with traditional medications that do help. But we do find a similar number in autism, similar types of dysfunction that are immune-mediated and immune-related. There can be literature supports an immune component to it somewhere between 20 and maybe 40, maybe 50%. So it's not a small number and a small percentage, but I couldn't give you an exact number because that is not yet known.
And then the second part is they ask if some of the 5 tests that you do come out positive, are there standard protocols for treating them?
Yes, there are some. If you look to the PANDAS physician network, there are some standardized protocols that walk through different treatments. And PANDAS, I say whether the patient has PANDAS or not, is a medical model for the treatment. And right now, what they're doing is looking for the infections, treating the infections, see how much the improvement is, treating inflammation if that's still there, and treating the immune system. And so right now, we as a company are working on developing an artificial intelligence machine learning algorithm based upon all of the results from all these patients to see if we can actually bypass and help identify which treatments would be most effective prior to actually being treated based upon the data that we've collected from all of these patients. We're probably a year away from actually getting that completed, but the goal is to eliminate the trial and error process. But the first step is to direct the treatment towards the underlying immune system and the infection versus treating the symptoms. So there are protocols that do that are available and published, and they fall into those categories.
All right, thank you so much. We have another question from someone, it looks like regarding specific testing results. So it sounds like it looks like they've had a couple of tests done. Originally, their autoimmune brain panel showed a high CAM kinase with normal levels of autoantibodies. And then a repeat test now shows elevated D1 anti-lysoganglioside and antitubulin and a borderline CAM after 14 years. Is this still an infection or just autoimmune? Yeah,
what you just described here is what we do see after an initial infection or an early infection or a reinfection. We typically see the CAM elevated and the symptoms associated with the CAM. Over time, what we will see is the CAM return to baseline as the immune system tries to deal with this, and these other autoimmune antibodies start to show up, and symptoms begin to sort of modulate or change. It does mean, one, because we're not really testing for infections, there may or may not be underlying infections, but typically, if there's still antibodies that are elevated, there can be. And sometimes what we find is that these other infections have not been identified yet, but the fact that the others are positive indicates that there's still an immune-mediated dysfunction going on that would want to respond. You would want to be treating with some type of anti-inflammatory immune modulator, and the possibility that you may want to keep looking for other infections in what we call this bad actor list, because they tend to continue to show up. Again, if there's still an infection, it's still triggering these autoantibodies to be responding. So it's quite possible. And what's described here is a typical progression of the immune system trying to deal with that. My question would be, what types of treatments have been done, and how has the patient responded? And are there other symptoms that still haven't responded to treatment?
Thank you so much. And then I would like to take a moment to mention that as far as insurance reimbursement, we do submit on the patient's behalf, and that most patients do receive some level of reimbursement from insurance for the testing. They may not cover the full cost of the test, but there is some portion usually, and we have a great team that will help submit that.
Someone had their hand up again there.
They did, but then it went away.
Yeah. Is it there? Can you hear me?
Yes, we can hear you.
Okay, I'm back. I'm the guy who referred to the drug-induced lupus. If after testing with you, if it was determined that it was not related to an infection, I mean, since you're sitting here and we're all kind of thinking on the same page, if the autoimmune system becomes a bad guy because of a drug that's used, in a short paragraph, would you describe how you would attempt to pursue future diagnosis other than using your own panel?
Yeah, again, with all the disclaimers, because I don't want
Or
to
treatment,
something.
shall I say?
So both for treatment and diagnosis, you clearly have an immune dysfunction that's triggered by minocycline, which has been reported in literature, and there are publications showing that what's happened and how it's been treated, or how it's attempted to be treated. Autoimmunity can tend to be not just against one classification or category. For instance, many of these other autoimmune antibodies, like what's called GAD65, NMDAR receptor encephalitis, many of these rarer ones where patients will have these real severe symptoms of psychosis and different things. If you've heard about the book Brain on Fire or the movie Brain on Fire, it's where Susanna Callahan ended up in the ICU because autoantibodies against a specific NMDA receptor. Quite frequently, and not always, but a high percentage of those also ended up what we call paraneoplastic, meaning that the immune system also has not been able to identify properly cancer cells. So sometimes, and not infrequently, you will see that the immune system has also missed or not been able to recognize cancer cells, and therefore sometimes they'll find that in conjunction with this, they'll look for cancer. Now, it's not related to these antibodies we're talking about, but the others. And I say that to point out that a person with an immune dysfunction can have multiple targets. So it's possible that if they do have autoantibodies for an immune dysregulation that's triggering the lupus, if they have symptoms of neuropsychiatric and behavioral disorders, they could have autoantibodies that are directed against these other brain proteins that we mentioned. If that's the case, then you would want to treat these the way that they have in these publications, as far as looking at, again, are there any infections? Maybe not. Is the immune system causing an inflammation in the brain? Treat the immune system inflammation. Is there autoantibodies that are directed against these brain proteins? Treat them with immune modulatory treatments as described. So without trying to get into too much detail as far as that, often it is good to look at, are there autoantibodies present that are directed against these brain proteins? And if so, that may give a clue as to how to go about to treat all of them.
Thank you very much. I appreciate that.
Good luck to you, too. I know that that's a challenge because that was not the intention, especially when you're trying to treat something so as common as acne, but a reaction to a specific drug that may start and trigger this. So let us know if we can be of help to you.
Thank you. I'd like to just also add that the people that I spoke to over the telephone from your company were some of the, shall I say, warmest, kindest, least aggressive medical treatment vendors of all time. Period.
Well, thank you, and we really appreciate that feedback because everyone's here because they know the suffering that you and family members go through, and it's a mission that our intention is to help change and transform how medicine is practiced for those suffering with these disorders. So we appreciate that. Thank you very much.
And thank you. Good night.
Okay.
All right. That's all the questions pending that I have, unless anyone has a burning. Oh, we got a hand raised. I could figure out how to allow that. I have my hand raised somehow. There we go.
Hello. Hi, my name is Jamie Liggins. I don't see how to bring my face up, but I'm just going to talk if you can hear me.
Yes, we can hear you.
Perfect. I'm intrigued by this because I was exposed to some toxins at in a building. I did a mycotoxin test and found out that I had toxins in my body. But for the past 12 years, I had been having seizures, and the medicine is not working. I've tried various, they've changed my medicine maybe about 6 or 7 times. They wanted to do brain surgery, but when I saw this, it's
Jamie, we lost your voice. Are you still there? Your audio is gone.
there.
Oh, now we can hear you again.
Okay. So this was interesting to me. I just took the test for the Cunningham panel. I guess it was formerly called Cunningham panel. So I'm waiting for my test results. Have you heard of anything like this where people were drug resistant from seizure medicine?
Yes, actually, we have some studies with several doctors on patients who have treatment-resistant seizures, and we are studying whether or not some of these autoantibodies are involved and or are they related to an immune dysfunction. The other part, so we don't have that answer yet. We're studying that. We're testing these patients, and we're looking at this with several doctors because it does seem to be a recurrence in these patients that have these immune-mediated neuropsychiatric disorders. You have described something else that, again, falls into this other category, not a bacteria, not a virus, but often fungal infections and mold and mycotoxins that are involved, and sometimes co-infections that confuse this. Mold and various types of fungi produce mycotoxins that can be neurotoxic, definitely impact and reduce the immune system's response, but also can cause and trigger many of these different types of neurologic disorders. If the immune system has responded in a way that you do have autoantibodies, then that's helpful. Often in mold-induced types of situations, you do have to treat and eradicate. Sometimes it's in the environment that an individual is in, and then sometimes it's just in the individual's body, and there needs to be sort of a detox, a cleansing, and then a healing of various things. So those many integrative and functional medicine doctors have come across and worked with and done. So you're heading down the right direction to find out what is the underlying root causes of these. And then from that, I think you'll have a better understanding of what direction to go. But a lot of this times, as we've mentioned, it does take time to get to this because it's not as commonly understood as we would hope to, and hopefully that'll change in the future.
Got it. That's good to know because when I went to the rheumatologist, she told me you have anti-phospholipid antibodies,
Hmm.
and I had no clue as to where that came from.
Mm-hmm.
I do not have lupus. I don't have rheumatoid arthritis, but I do have, she said, not the disease, but the antibodies.
Mm-hmm.
So that was interesting.
Mm-hmm.
Didn't know where it came from, but that sounds like what you just said. I could have some antibodies in my system,
Mm-hmm.
and perhaps they said if the test came back positive, then it would be immunotherapy treatment.
Mm-hmm.
What actually is that, doctor?
Yeah. So there's various different treatments for immunotherapy. Some of them include intravenous immunoglobulin, which is the antibodies that are collected in the blood centers that are provided and infused in the vein. Some is also steroids, which dexamethasone, prednisone, things that are either oral or IV to reduce the inflammation. Others can be, like I mentioned, the plasmapheresis, which is a little more, I guess, invasive therapy in the sense where you're taking the blood out and removing the antibodies and putting the blood back. There are others, and other doctors and other clinicians have identified certain types of natural products, let's say, formulary FDA sort of products that modulate the immune system. And of course, some of these things can and have been shown to be effective in combination with others. Something as simple as NSAIDs or nonsteroidal anti-inflammatories sometimes are used. So there is a host of different types of immunotherapies, and that's something that really there's a progression as to which ones to use depending upon the symptoms and the results of testing.
Perfect. I missed the first one that you said.
Intravenous immunoglobulin. So it's also called IVIG. And Ashley McCammett here is a nurse and has been involved in infusion therapy in places that actually do this for doctors and patients. So those are things that are quite commonly given to many different types of disorders that have been involved with, let's say, the immune system dysfunction or immune dysregulation.
Got it. I saw that on the internet. I was doing some reading and I saw that. There
Mhm.
was a doctor that I saw that was doing vitamin infused IV treatment.
Mhm.
And I think she was using glutathione, phospholipid complex. I can't remember how to pronounce some of those words,
Mhm.
but it was interesting because it says some of those things help repair the mitochondria of your brain.
Mhm.
And so it looks like I'm on the right path because the both of you are smiling.
Well, that's good because often what happens with these disorders is other metabolic systems go awry, including mitochondrial dysfunction, including metabolic dysfunction. Glutathione is actually a compound that we normally produce in our body that is called a free radical scavenger. And what it does is protect our body from dangerous and things that could destroy and kill cells and do other damage. So often what they will do is they will infuse this in an IV, and there's actually oral and other ways in doing that, but it can and very will help with many of the symptoms that are a result of the side effects of these types of things, and including, since you mentioned mold, often glutathione has been found to be helpful in at least some of the recovery and some of the symptomatic process. It's not the only or the complete solution, but it definitely can help make a person feel better.
Okay. Thank you so much, both
Mhm.
of you. I appreciate that.
Yes. Good luck to you too. We have one more hand up or something.
We do not have any more hands up. I don't see anything new in the chat, nor is there anything pending in the Q&A. So I believe we answered everybody's questions.
Okay.
And as you mentioned, if they have any further questions, they can access our website at moleculera.com. There's chock full of information. And with that, I believe we can say that this concludes our webinar. Thank you so much, Dr. Shimasaki.
Thank you.
And as a reminder to you all, you'll be emailed a recording of this presentation within the next few days. And we thank you very much for attending and for your participation. And we look forward to connecting with each of you soon.
Thank you.
Thank you. Good night.